Good afternoon, Dr. Baker.
Good afternoon, Omar. How are you?
I'm fine. To start off, could you tell me where you went to medical school?
I went to Tufts University Medical School. I graduated in 1954.
And when did you start practicing?
Actually, I took an internship in St. Mary's Hospital, Grand Rapids, Michigan, and a residency at St. Luke's Hospital in Chicago, now Presbyterian St. Luke's, and finished my residency in 1959, and that's when I began practicing medicine.
What did you choose as your specialty?
I chose surgery and took a 4-year residency in surgery at, as I said, at St. Luke's Hospital.
And what made you choose surgery as a specialty?
You know, I think I didn't choose surgery so much with the intention of practicing surgery, but because I anticipated that I would practice medicine in some sort of a primitive circumstance, either in a missionary atmosphere or some other kind of circumstance where I thought the practical things that I would learn in surgery would be helpful. In my youth, I always sort of admired Albert Schweitzer, the philosopher, missionary, theologian, musician who ended up practicing medicine in French Equatorial Africa, and that was sort of going through my mind, I think, as I was trying to formulate my medical career.
Okay. So could you describe a typical day when you first started practicing medicine?
Well, I first started in, I worked for a few years in a clinic in New Ulm, Minnesota, and there the routine was as usual. You know, we start hospital rounds in the morning and then go to the clinic in the morning and the afternoon, and that part of my life was pretty routine and pretty predictable one. And then I came back here to Whitensville, where my mother and father lived, and my father was having certain financial difficulties, which really brought me back here. And I sort of settled into that same routine. Hospital rounds in the morning, and then house calls, and I did do house calls in those days, and then office hours in the afternoon, and office hours also 4 evenings a week. And that was sort of a fatiguing routine, and also I felt it was quite confining, especially when I compared it with my original ideas about what I was going to do in medicine were.
So what were your hours like practicing in a typical day?
While I was practicing here, it was really very fatiguing, because if I had evening office hours, which I did 4 days or 4 evenings a week, then after that there was usually a couple of house calls, and it wasn't unusual for me to end up my day at 10, 11, even midnight, and that was really a very demanding schedule.
Did you often use the telephone to talk with patients?
Oh yes. I mean, I always felt that when a patient gave you or called you on the telephone, there was a professional obligation to respond to that call. And I have to say, to this day, when I call somebody on the telephone and they don't respond to me or my call, I really feel professionally offended, because I say to my wife at times like that, if I behaved like that, they would run me out of town, whether that's true or not. But I always felt that if a person called you on the telephone and wanted to discuss something, that you were professionally and personally obligated to respond.
What were your rounds like at the hospital?
Oh, they were pretty routine, and I didn't have really that. This is a small town, of course, and I had a few patients in the hospital regularly, but if there was anything of any severity, we referred them to the specialists in Worcester, so that most of the severely ill patients were hospitalized in the hospitals of Worcester.
Who were your patients typically?
Well, they were, you know, people in the town, and I belonged to and grew up in a church community here, and many of the patients came from that church community. And my father had peddled milk in this area. He was a dairy farmer in Uxbridge, and many of the people who knew my father responded to their, okay, friendship, respect for him, whatever you want to call it, by calling me as their doctor when the occasion arose. So it was a fairly varied, and I very quickly, over a few months, I developed a very energetic practice.
Did patients choose their physician?
Yes. Oh, yes. I mean, that was in the early 60s, and the HMO concept and like what is just developing. I think the forerunner of that in this area, of course, was Dr. Fallon in the Fallon Clinic, and that was just beginning. And so for most of the practice it was carried on here was private practice, fee-for-service, very simple by comparison with what is taking place now.
What do you think it was like for your family to have a physician in the household?
I think it was very trying. I must say that as my children were growing up, I became very aware that there were many things happening in their lives that I wasn't a participant of, and that the hours and days that I spent, much of which were outside of the development of the family, and that really kind of bothered me quite a bit as I say, as the time went by. And I became rather determined rather early that there should be another way to practice medicine, and I was going to try to find it.
When did you see your family?
Mostly at the end of the day, and oftentimes the kids by that time would be in bed, of course, so it was sort of unsatisfactory. I found it very unsatisfactory.
Did you have any vacations?
You know, I can't remember. I don't think vacation was a very big part of my life. I remember I used to take Thursdays off. Most of the doctors in the community took Wednesday off, but because I was the newcomer and I thought, well, I could benefit from the patients that needed a doctor when they were absent, I took Thursday off. But as far as vacations were concerned, I don't remember an extended vacation during that 3 or 4 years that I practiced here.
I remember you mentioned a little bit about why you became a doctor when you talked about choosing your specialty, but is there anything else that made you decide to become a doctor, any other fact that you didn't mention?
Well, I think that's an interesting question because, you know, 50 years ago, 60 years ago, role models were important, but not as prevalent as they are now. And the person who really impressed me, I have to say, was the family doctor who delivered me when I was born and who took care of me whenever I was ill. And that was Dr. Harold Williams, who also was a practitioner in this town for many, many years. And I think it was my attraction to the dignity of Dr. Williams and the professionalism of Dr. Williams and what he represented to me and to our family as a physician when we were in a position where we were frightened by illness and disease. And I think that was the major attraction that drew me towards being a physician. As the years went by, I developed other interests. I developed interests in literature and so forth and so on, and now I'm trying to mix those things. But when I was a young boy, I think that the main attraction or the main reason I became a physician was because of my admiration for Dr. Harold Williams.
And once you started practicing, what made you decide to keep being a doctor for all these years?
Well, there's something, how'd you say that, satisfying about being a doctor, by entering into people's lives and having the privilege of being able to help them and having them, number one, respect you because of the position that you hold in the society, and number two, and number three, or whatever, for the appreciation that they reflect when you were able to help them. And I think that's all very satisfying, and certainly one would think very seriously before he would abandon a profession that gave rewards like that.
Why did you choose to practice in the Worcester area?
Fact of the matter is that the main part of my practice was not in the Worcester area. I practiced here in Whitensville for about 3 or 4 years, and then I decided that private practice in this kind of a setting was not what I wanted for my life. And so I began to cast about for different ways in which I could practice medicine, and I ended up being a medical officer in the Foreign Service of the United States Department of State. And in 1963, my wife and I and 3 children joined the Foreign Service, and that was the beginning of a career that extended over a period of 28 years.
And where exactly did you travel?
Well, I mean, that's, as you might say, that's the story of my life. And the first assignment we had was in the Yemen Arab Republic, and that we came there in 1963, and that was a time in which people said that the Yemen was rushing headlong into the 14th century, and we came into such a primitive area that it was what you could call mind-boggling. And I had a clinic there, and I was the embassy medical officer, and in that sitting I took care of the United States government then had 2 projects there. It was building a road, and it had a water project. And I took care of the embassy employees and the employees of the Agency for International Development and the Bureau of Public Roads who were taking care of this, who were taking care of these projects. In addition to that, because of the very primitive medical condition of the country, the aid director asked me if I would mind taking care of some locals, which I certainly did. And it was a very energetic experience.
Do you have a favorite memory from when you practiced?
Well, when I was practicing here in Whitensville, I was having office hours one evening, and every time I opened the door, I saw this young lady who was little girl who was sitting out there, and finally she came into the office and was sitting in front of my desk, and I said, "What can I do for you?" And she said, "Will you kill my frog?" And apparently this high school was having a biology project, and she wanted to dissect out the nervous system of a frog. And she didn't know how to kill the frog, I guess, without injuring its anatomy. So she asked me if I could kill the frog by some means that she would be able to perform the dissection without having the outlines of the frog distorted. Actually, I called the local pharmacist, asked if he'd give me some chloroform, put the frog in a jar, dumped the chloroform in the jar, and but anyway, that lingers in my mind after all the years.
Do you have a least favorite memory from practicing?
No, not really. Medicine gives opportunities for elation, but there are also times of discouragement. And well, I guess I would have to say the least favorite memory I had was a young baby whom I had delivered only a few weeks or months before, who died from sudden infant death syndrome. And that was rather traumatic and, really kind of shocking for me. But there was, in a sense, a pleasant story to it, because a few years later I was able to deliver from that same mother another baby, so that the shock of the loss of the first infant was a little bit tempered. It's never an occasion when one child replaces another. That's impossible, but at least it wasn't completely sad from the point of view that the mother and the father too did have other children, and gradually the trauma does wear off. But that was an experience that I won't forget either.
What were the most typical illnesses that you dealt with in the 50s and 60s?
I think that you know, it was pretty run-of-the-mill with respiratory, you know, throat and lungs, and occasional gastrointestinal with an appendix thrown in, and the children with the usual childhood diseases. I think that what I encountered certainly in my practice here was pretty routine. And then when I get in the Foreign Service, it didn't change that much, but it much more focused on gastrointestinal with amoebiasis and, okay, the paratyphoids and the enteridides, and I mean, that was an important part of Foreign Service life. But the diseases I always found were at least fairly run-of-the-mill.
How about in subsequent decades, later in your career?
Excuse me?
Later in your career, did the illnesses that you treated change at all?
I think that the pattern of illnesses and the kinds of experience that I had, I really never had to come to grips with the AIDS epidemic and occasional venereal disease, but you know, the AIDS epidemic, which impinges very heavily on medical practice now, I really never had to come to grips with that. And I would say, in many ways, the polio had disappeared, and the energetic child vaccination programs had really ameliorated the contagious viral diseases of infancy and childhood. And so that part of the clinical practice of medicine, I think, in the last years changed.
When you started practicing, what was the greatest challenge for you to treat?
I think when I first started, I was an intern at St. Mary's, and okay, that had to be in 1955, and during the summer we would see polio cases, and I remember polio patients, and I remember a young man in an iron lung who died because while he was on the respirator, his family fed him ice cream, and the ice cream was sucked down into his respiratory tract. Just a tragic kind of thing you can imagine. But those, over the years, with the vaccine and Dr. Ender's success in producing a vaccine, a polio vaccine, that changed. And now, okay, with diphtheria and tetanus and DPT, the pertussis, and now the vaccines for measles, mumps, and rubella. I mean, the sort of the infant and childhood kind of disease pattern has changed substantially.
How about when you stopped practicing? What do you think was the greatest challenge for doctors to treat in your field?
I would say, when you talk about one of the most frightening things that I always feared and encountered, not only in my practice but my Foreign Service practice, was children with croup. I mean, that's always frightening, and so you feel there's so little you can do. But anyway, that fortunately, I never had seen a child who died with that kind of circumstance, but it is very frightening. But you say, as I left medicine, one of the things that became very challenging was antibiotic resistance and the pattern of diseases and the antibiotics to which they were responsive. I mean, that changed substantially. And I remember in the beginning when you got into a narrow corner, you could always, chloramycetin was always a medication that you could pretty much depend on. But then it became clear that chloramycetin caused blood dyscrasias and anemias, and so you became really frightened about using chloramycetin too. And I was just looking in the PDR this morning, and if I look correctly, chloramycetin is hardly on the market anymore. You can just get it in eye drops and things like that. But to give it systemically, it seems to me that chloramycetin has developed a very bad reputation. But now, of course, there are other medications, but Keflex and the new antibiotics, but once again, the overuse of antibiotics and the irresponsible use for antibiotics, I think, is presenting, I mean, using it in agriculture so that cattle will gain weight more. And I think that is very frightening, and that the end of that story we don't know yet by any means.
So would you classify the polio vaccine as one of the most important breakthroughs in disease prevention that you've seen during the course of your career?
I would agree with that. I think that was a real giant step for mankind, as to paraphrase a famous quotation.
How about in disease treatment? What's a great breakthrough you've seen in that field?
Well, you know, I mean, the equipment is so much improved too. I mean, before we had X-rays and GIs but then when we wanted to investigate the spinal column, you had for enucleated discs and so forth, you interjected Lipiodol into the spinal canal, but now with the MRI and the CAT scan first, and then the MRI and all the echocardiograms and all the kinds of non-invasive, very particular mammograms. I mean to say, I think that these kinds of scientific breakthroughs in the technology of diagnosis are just absolutely incredible. And you know, proctoscopy. I mean, you know, you had this 1.5-inch metal tube with which you investigated the lower part of the gastrointestinal tract, the sigmoid colon. And now with flexible colonoscopy, you can go all the way around the colon into the cecum. I mean, these are just wonderful advances from a diagnostic point of view.
What was the worst epidemic that you can recall?
Well, as I said, when I was an intern, the polio patients were coming into the hospital, and I think those days of the polio epidemic were the most frightening. And during the summertime, every family worried about poliomyelitis every time they went to the beach or every time they went to a gathering of people. And I think that the elimination of that fear was one of the, that probably ranked with the elimination of smallpox many, many years ago.
Could you describe attitudes towards smoking and cancer throughout your career?
I think there was a cavalier attitude about smoking, and I think that you know, there was the development of the idea that smoking was smart and cool, and you know, even doctors were telling people that Camels were easy on their throat and good for their T-zone, and I mean, when you look back on it, it's almost scandalous what the way the attitudes, even of the medical profession, towards smoking. And I have to admit, for a couple of years when I was in medical school, I smoked, but and then I found it personally unpleasant and personally unrewarding, and so it never has been a part of my life. But at that time, I certainly didn't realize what I realize now about smoking. And one of the things I've done in my retirement was to be a member of the Board of Health here of the town of Northbridge. And I assure you that I have used all the energy and effort that I could muster to get a no-smoking policy around the town. And we do have smoke-free restaurants in Northbridge now, except for bars and places where young people don't legally come. And to introduce into the schools an idea or education program so that children will realize the dangers of smoking. And I think smoking is you know, the slogan, "Let's make smoking history." It would be a wonderful thing for the human race if it would happen. When you think about the number of people who die from malignancies from smoking, and the fact that since smoking has become popular with women, that carcinoma of the lung is now more prevalent in women than carcinoma of the breast. I mean, it's really, and the fact that the smoking lobby has so much power and is able to fend off these public health initiatives is really very sad.
In terms of technology, what is something that doctors take for granted now that you didn't have in Worcester?
Well, I mentioned that the CAT scans and the MRIs. A few months, weeks ago, I developed symptoms of pain in my side and so forth. And I thought I was having a heart attack, to tell you the truth. But it turned out that I have a ruptured disc in my neck. Well, okay, I had an MRI which demonstrated that very clearly, and that was a technique developed within the last few years, decades. I don't know the chronology of it, but that is an advance that I think is very substantial and very important. And think of CAT scans, and think of the diagnostic abilities of abilities to diagnose tumors of the brain and defects and changes in cerebral blood flow and spots where the activity in the brain is compromised. I think all those kinds of techniques are so really substantial. And I think the primary diagnostic tool when I started was the EKG, in terms of cardiac disease, was the EKG, and now you get echocardiograms, and think of all what's available in terms of cardiac diagnosis that wasn't here, say, 50 years ago.
So what technology is still used today that you use frequently in your practice?
Well, you know, X-ray is still there. Chest X-ray is still the cornerstone, and upper GI, or gastrointestinal X-rays and all those kinds of things, and blood tests. But then you said you want an individual blood test. If you want a uric acid, you ordered a uric acid. You want a calcium, you ordered a calcium. But now then the multi-channel kind of diagnosis came. So you take a small specimen of blood and you submit it to a diagnosis, and you come up with 17 different profiles, or 17 different items in a profile, and liver profiles, and I mean the amount of information that a person can get from blood chemistry now is actually mind-boggling. So, okay, blood cultures, we did those in the beginning, and they're still done, of course, I'm sure, in a much more sophisticated way. But that was a technique that was carried on early, and that is being carried on still. But I think advances in radiology, advances in bacteriology, and advances in blood chemistry and hematology. I mean, just think of these blood scanners now. They put a drop of blood through, and they can analyze the profile of the blood, and those are really very, substantial gains which patients benefit from a great deal.
Describe one important invention that you've seen throughout the course of your career.
Well, I've mentioned several, of course, but one that I haven't mentioned yet was amniocentesis, and that developed, in which at least you can take a profile of amniotic fluid and make some kind of determination about any kinds of genetic defects that a child might take. Of course, that opens up a whole area of the morality of medicine, and there are people who can argue or who can discuss many elements and aspects of that. So oftentimes inventions that come along are not without discussion, and I think probably what falls into that also are the advances in how I say population control and birth control. And Dr. Rock and the people up here in Shrewsbury have introduced the ability to control ovulation, which opens up a whole new vista of lifestyle possibilities. And this is a question that's still being argued back and forth about the benefits and the hazards, and it boils over from the field of science to the field of morality. So there are just all kinds of questions and all kinds of problems which develop with the advance of science and technology, because science and technology are not independent. They are related to lifestyles, values, and so it becomes very complicated.
Did you always have access to the new technology in your field?
No. You know, I had a little medical unit in an embassy in, Baghdad or Moscow or Beijing or wherever I was stationed, Kabul, Afghanistan, and I had a practice in a real sense, seat of my pants medicine in that kind of a setting, so that if I had any questions about what was going on, I had to refer my patients to a medical center. Usually it was a military medical center like Wiesbaden in Europe or Frankfurt or something like that. In China, I used to send patients to Hong Kong for diagnosis. So in a real sense, in my capacity as an embassy medical officer, sort of practiced seat of the pants, as I say, at medicine. And if I had serious diagnostic problems, I had to send them to a center where they could be adequately taken care of.
Is there anything that you would like to see invented now?
You know, I read that question, and what I thought about was, okay, a cure for AIDS. Says everybody, that's something that would revolutionize medicine and make many people, doctors especially, very, very happy and pleased. And I really admire the physicians who make it a practice to deal with the people who are suffering from AIDS. It must be very discouraging, but nevertheless, that hopefully will come along somewhere along the way, like it did for polio. I thought, you know, obviously with all the people who are waiting for heart transplants, it would be very wonderful if artificial mechanical heart that was efficient, economical, not too bulky, dependable. Okay, there are some people who have artificial hearts now, but I think that it must be very difficult to conduct one's life in any sort of a normal fashion with the kind of mechanisms that are available at this time. And I know that people are working very hard on this, and I think there's a long way to go. When you see how your television thing here is miniaturized, I think it's not beyond hope that something like that will happen.
Did you always have access to the drugs that you wanted to?
Yes, I did. I had a catalog, and the State Department was very generous with the kind of pharmacy that I could stock and support, and any medicine that I wanted I could get without argument. So I would say the answer to that was yes.
Briefly, could you describe some of the drugs that you used in the early part of your career and how they changed throughout your practice?
Of course, when I was a kid, I had what the family physician thought might be rheumatic fever, and he gave me sulfanilamide. And I did take it, and lo and behold, I apparently crystallized some of it in my urine and ended up with bloody urine, which, okay, that was the end of my sulfanilamide career. But then, over the years, of course, penicillin came along and revolutionized medicine. Certainly, that is one of the most incredible things that happened. And okay, that came in World War II, so when I began practice, medicine was available, and tetracycline was a good antibiotic that one could use as an alternative. In the cardiac treatment, I remember using digitalis, but that soon was displaced by the digoxin, which was easier to administer and much more effective. But I remember a patient when I was an intern and a patient when I was in practice who died of heart block, and there were no satisfactory kinds of approaches to heart block at that time, and sudden death all too often was the result of that. But now those kinds of difficulties can be dealt with. As I mentioned earlier, chloramycetin was a good medication to fall back on. We always used it when you had any typhoids or paratyphoids or anything like that. But it did have its drawbacks, obviously. But, okay, those are the things that come to my mind as you talk to me now.
How did changes in the drug industry affect your practice?
Actually, you know, the kind of practice I had, I have to say that I didn't know that kind of... When I was in practice here, the drug detail people would come and leave samples, and I used those samples to pass on to patients, especially those who were not too well off. But in the Foreign Service, I didn't encounter that kind of detail and that kind of approach. So that wasn't a concern of mine.
Okay, well, I'm going to move on to access to care now. How did patients without money get health care?
You see, I practiced in a government setting, and all the people that I took care of were entitled to medical care, and their medical care was what I could provide them locally. So I really, that's the aspect of current medical practice that practitioners today encounter that I had no experience with.
So you think that everyone who needed care received it?
Yes. I mean, that was the name of the game, right? That's what I was there for. I was like a medical officer in the Army. I mean, and it wasn't a question of a soldier comes to you, those kinds of concerns just didn't, they didn't develop in the kind of medical setting that I was practicing in.
What were some fears and concerns about socialized medicine in the 50s and 60s?
See, I practiced socialized medicine for most of my professional life, so these are, I mean, actually, I was in an office and people came to me and I didn't collect any money and they didn't pay any money, and I functioned in a complete socialized medicine environment, and the concerns that are out there today in the civilian sector, I just didn't have any kind of experience with that or any kind of concern for that. I was completely isolated from that.
So were physicians involved politically on this topic? You might have
No, once again, that's an area of medicine and medical politics that I was completely isolated from.
What were your feelings on Medicare and Medicaid when they came into being in the 60s?
Well, in the 60s, I was in the Foreign Service, so I was working for the government. But I will say that I think that everybody's entitled to medical care, and that any government programs that extend the parameters of access to medical care are beneficial for the community, and the fears and alarms that are raised about socialism and socialized medicine have to be evaluated very carefully in terms of providing health care for the as broad coverage as possible for the community, so that the poor don't find themselves out on a limb looking for medical care, and medical care for which they can't pay, medical care for which they have no access. I mean, a society has to have a heart and a conscience, and if it's just going to be strictly for profit kind of medicine and medical care, I think that it doesn't fulfill the idealized role which, in my mind, medicine should fill in a community.
So would you agree that over the years since you started practicing, that government has become far more involved in healthcare than it used to be?
Yeah, I guess I'd have to say that from the point of view of, so Social Security expands out into Medicare, and it certainly has, and medical research and the FDA and its attempt to see that improper medicines don't get onto the market, and there's a need for that. And we all know the story about Dr. Kelsey and thalidomide. So the government has to be involved too. And okay, that's the perpetual kind of discussion that goes on in a democracy, and we're seeing it now with business and the corporations. How much government and how far should it go, and where is too much and where is too little? And that, I presume, is a discussion that will go on I think for my lifetime, maybe even yours.
So what would you like to see happen with the government
In healthcare?
Yes.
I don't know. I think, and after you tape this, you probably better put this in a dark closet, but I think a universal health program of some kind would be a good way for a society with a conscience to see to that all people have access to medical care that's adequate, satisfactory, compassionate, and sufficient.
Did HMOs ever impact your practice?
No.
Okay. Do you have any opinions on the positive or negative aspects of HMOs?
Well, I practiced with a little office and a telephone and a local hospital, and people called me, and it was very fatiguing. And I think that that kind of practice is almost impossible in this day and time. And I think that a health maintenance organization is probably necessary for the physician, for the patients, for the equipment and facilities that it takes to run a good medical office, I can almost hardly see how an individual private practitioner could practice adequately for either himself or his patients in this day and time.
How much money did you pay to go to Towson Medical School?
You know, actually, most of my education was with the GI Bill of Rights, and I got my college and maybe first 2 years of medical school, and then I had to, my father was the one who helped me, of course. I think it cost about 20,000, I was trying to think about that, $20,000 a year, $10,000 to $20,000 for 2 years. And okay, we were able to scrape that together by ourselves. So I didn't go into debt for purposes of my medical education. And I must say, the big contributor to that was the GI Bill of Rights.
So how do you think the cost of your medical school compares to the cost of medical school today in terms of influencing the choice of young doctors after they graduate?
I think that the cost of medical education now is astronomical, and that, you know, the amount of money that a physician who comes from a young medical school person who comes from a family of not abundant means, the amount of money that he has to borrow, and the amount of indebtedness that he has to develop is really very limiting. And I think that the kind of career choices that I made would probably be impossible if I had to borrow the many tens of thousands of dollars which a young medical student at this day and time has to borrow if he doesn't have wealth behind him.
How have doctors' salaries changed over the course of your practice?
I think medicine clearly is very lucrative in this day and time, and okay, I think the living that I was making as a private practitioner here was modest, but the salaries that doctors are making now are substantial and approaching satisfactory. Of course, they're not by any comparison to a CEO of a big corporation or an entertainment or sports star, but doctors, I think generally do very well. But that's a part of medicine that I never participated in, so I have very little feeling for that.
How has malpractice insurance changed over the years?
Well, that's an incredible subject. When I was beginning practice, malpractice premiums were a very small consideration from the point of view of expense. And medical malpractice suits were very rare. And I did carry malpractice insurance for, okay, both as a resident and as when I was practicing here. But the premiums were, it was St. Paul Insurance Company, if I remember, and they made a specialty of malpractice insurance. But now, malpractice insurance premiums are astronomical. Malpractice suits are more than common, and I really feel very thankful that when I was practicing medicine for the United States government, I didn't have to be concerned about malpractice because, as you may know, the United States government covers its physicians in its military and in civilian organizations against malpractice suits. So I never really, when I was employed by the United States government, I never had to worry about malpractice premiums. I'll make another point, and that is, one of the things that I did after I retired was that I used to do volunteer short-term assignments for the Indian Health Service through the American Medical Association at Indian reservations around the country. I spent, 3-4 times a year I would go out to reservations in North Dakota, South Dakota. I went to Nevada once. And in those kinds of circumstances also, the United States government covered the physician for his malpractice insurance. I think the malpractice scene is very destructive. It intimidates the doctor. It makes it made me fearful oftentimes, and it encourages patients sometimes to seek redress in circumstances and situations where that's not appropriate.
How did you learn the business of medicine?
I know nothing about the business of medicine.
Okay, let's move on. What are some changes that you've seen in the demographics of the Worcester community?
Well, I live down here in the southern Blackstone Valley, and the National Park Service has come in with a collaborative, and they've developed the Blackstone Valley Heritage Corridor built around the dynamics and the energy of the Blackstone River, which drops about 418 feet between Worcester and Providence, and that 418 feet energized the area so that it became the site of the Industrial Revolution in early colonial America. And I think we were just a quiet little community, or a quiet little area. I grew up on a farm up in Uxbridge on the top of Williams Hill, and when the National Park Service came and told us about the Blackstone Valley and the Heritage Corridor, I mean, that was really a wonderful thing. And now, if you know, we have a museum in Woonsocket, and there are sites along the Blackstone River, down in Uxbridge and so forth. And people have got a sense now of the history of the valley, which is in cultural events built around that, and it's just this has changed the environment and the idea that people have of the valley just incredibly. But now, with 495 and 90 and 146, I mean, this Blackstone Valley, or this southern Blackstone Valley, is the site of an incredible housing boom. You wouldn't believe what's going on here. And now the MTA has got railroad stations in Worcester, Grafton, Westboro, and people are increasingly using the train to commute to the cities. And this is adding to the number of people that are coming into their area. And if you grew up in this area, as I did, and you can look back on what was going on 50 years ago and think about what's happening now in the terms of housing and so forth, it's absolutely incredible. But the sad part, I think, is that all the houses they're building are so expensive. I mean, from the point of view of $200,000 to $400,000, and the thought that goes through my mind is, where does a poor person live? Or where does a person who's poor or of moderate means get the money to buy a house? You know, there's some kind of a tragic thing going on, and I don't know where it's going to end.
Has the ethnic background of your patients changed greatly over the years?
Well, I mean, that's again a question that didn't really affect me.
Oh, yes.
You know, my ancestors were Dutch, and there are many people in this community who are Dutch. There's a very strong Dutch kind of ethnic environment here. And many of my patients in the beginning, you know, focused on that, but over the years I think that kind of influence gradually fades. But that's a question that I can't really give any really intelligent answer to.
How did women's health in Worcester change over the course of your practice?
Say that, women.
How has women's health changed in Worcester over the course of your practice?
Well, that's once again a question that I that I have no real insight in. But one thing I will say in that term is that my wife, Marilyn, has been a part of the Women's Health Initiative, and she participated in this hormone study, and you know, right now she feels very pleased that she was a part of trying to provide the answer about hormone replacement therapy, which the information from which has now emerged and made such an important difference in the way women, menopause, and hormone therapy, its appropriateness or inappropriateness has been analyzed, and I think that she feels, and I feel with her, that she has made a very substantial contribution.
What were public perceptions of doctors when you started practicing?
I think that the public generally had a very high regard for doctors, and that, okay, that was probably one of the reasons why I chose medicine. And I think that in that day, in that time, doctors were looked upon very, very favorably and evaluated very kindly.
How do you feel the role of the physician in the Worcester community has changed over the years?
Well, of course, there aren't so many private practitioners now. They're the HMOs, as I said. Fallon, I think, was the leader in that. And there's a certain impersonalness that develops when a person is the patient of an HMO. And I hear people say, well, I went to the doctor this time, and it was a different doctor from the doctor I saw the last time. So people still make relationships with doctors, but I think they're a little more tenuous than they were, let's say, 40, 50 years ago.
Are there physicians in this area of Massachusetts that you admired when you started out practicing, aside from Dr. Harold Williams?
Yes, my grandfather had a malignancy of his kidney, and I think it was Dr. Bancroft Wheeler who took care of him, and there were names out there like that who almost had demigod status, I will say. But actually, I think that we looked upon the specialists at Memorial Hospital and St. Vincent in a very special way. And I'm thinking of some doctors at St. Vincent's who, Dr. McCrae, I think it was, but they had a very special status because people from this area were often referred to them when they were seriously ill.
Do you find yourself admiring younger physicians now as opposed to admiring older physicians when you started?
Yeah, I think so. I mean, I think the young physicians are very, and I used to go, in order to keep up with my current CME requirements, I went up to the lectures at the University of Massachusetts Medical School. And I think that, you know, when I left, there was no medical school up in Worcester, but now there's that medical school at the University of Mass, and I think that's just an incredible contribution to the medicine and the level of practice of Worcester County. And the young physicians whom I observed at those rounds at the University of Massachusetts, I think they were just incredibly bright, ambitious, and I think that medicine in this area has a bright future, largely because of the University of Massachusetts and the medical school.
What do you like best about practicing in this area?
I didn't practice in this area.
Okay, yeah. How do you feel that the role of the female physician in Worcester has changed since the 50s and 60s?
Well, obviously there are more female doctors, and there are no areas that are closed to them. I think it's just a wonderful thing, and I'm certainly in favor, in every way, shape, and form, that women should be equal to men in their rights and their privileges and their abilities to practice medicine or any other profession any way they choose.
And in 20 seconds, could you state what advice you have for younger doctors before we wrap up?
Work hard, study hard, don't get discouraged.
Okay, thank you very much.
And keep the faith.
That's right.
So what